Okay, everybody. So we're ready to our second talk for the day. Victor Rognos. He's here. He's one of our PhD students at the USC. We have 14 different projects we are financing, and his project is one of them. So he's going to talk to us the forefront of USC research, actually. We're really looking forward to it. Thank you, Victor, and I hope you guys enjoy.
Okay. Is it too loud, or I can talk more softly? Okay. Yes, as Eva said, I'm one of the PhD students at UAC. We are 14. I see some of them here today, not everyone. So my name is Victor, and I will talk about a survival analysis that I did on a clinical trial concerning colistin and meropenem, where I looked at colistin exposure. And I'm in the Department of Pharmaceutical Biosciences and in the pharmacometrics research group. And my supervisors are Lena, that sits in the back there, and also Mats Karlsson. And I will also tell you a bit about what our group does. So I've structured my talk like this. It's in 4 parts. So first I will describe to you what my project is and why I think it's worthwhile to do this project. And then I will talk to you about what pharmacometrics is. And I have some people from my group here, so we'll see if they agree with my definition. And then I'll talk about AIDA, which is a clinical trial. And that's where I got all my data that I'm analyzing. And then finally come back and answer the question about colistin's association with survival. And then in between each section, I'll have room for a question or two also. Okay? So as I said, my PhD project is part of Uppsala Antibiotic Center, and the working title of my project is Model-Based Design and Analysis of Clinical Trials on Drug Therapies Aimed to Overcome Antibiotic Resistance. So we're working with mathematical modeling and then applying these type of mathematical models to clinical trial data, and that's what I'm doing. And the aim of my project is to contribute and develop new and more efficient methods for clinical trials while still retaining the informative content in them. So try to make them more efficient, faster, and cheaper, but not lose any information that they give, so to say. And some people might already see the value in this. I will show you a survey now that was done on why this might have value. That was conducted in 2015, and it was sent out to pharmaceutical industry people. And the main challenges they saw were mainly financial and regulatory challenges. And the question they posed was what are the 3 most frequent reasons for stopping the clinical development of new antibacterial agents? And the 3 that came out on top were negative business value, or medical and scientific reasons, and then maybe lack of efficacy, and also that the phase 3 studies were unreasonably long, or they required unreasonable amount of resources. They had to recruit a lot of patients across many study sites. And I think my project can address all 3 of these. And something that's been written about this is to reduce the quantity of clinical efficacy data, for example. So try to reduce the requirements for phase 3 trials and instead rely more on phase 1 human PK data and preclinical efficacy data instead, and use that as information to inform the phase 3 trials instead. So my project then can be divided up into 4 parts. It goes something like this, not necessarily in this order. so I'm working on the first part right now, and the parts on like 2 to 4 are mainly in the idea stage right now, at least in my head. So I'll focus in on this the analysis part today. And also I want to connect back to the Sustainable Development Goals real quick and mention that I think my project really connects with Goal 3 and 9 concerning health and innovation in health. And then also connect to the Global Action Plan that I'm sure many of you are aware of. And I will show you the objectives of this one. And I'll highlight it then in black, like the objectives that I think connect most to my project. And it's mainly to, I think this applies to all research projects, strengthen knowledge and evidence base through research. And then number 4 here, to optimize the use of antimicrobial medicines in human health. And then also to develop the economic case for sustainable investment and increase investment in new medicines. So that was a quick overview of my project as a whole, how it connects to the bigger picture. So are there any questions on that so far? Crystal clear. Good. Because now comes maybe something you're not familiar with. So pharmacometrics. How many here, except people from my group, have an idea of what this is? One. And Lena, of course, there's. Okay. This will be, for people in my group, of course, this will be quite basic. But for the rest of you, I have defined it as this, that it's the modeling and simulation for PK, PKPD, and disease progression. I will tell you what these abbreviations stand for. So PKPD, it stands for pharmacokinetics and pharmacodynamics. And pharmacokinetics has to do with the interplay between a dose that you give and the concentration that you observe in a patient. While the, I'm turning towards here because my group sits there. And the pharmacodynamics then talks about the interplay between the concentration and the effect that you might observe. Maybe you've heard this quote, the dose makes the poison. So this is from Paracelsus. He's known as the father of toxicology. But I would rather say that it is the concentration that makes the poison. Because we know that it's the concentrations that drive the response, the effect or the side effect, the potential toxic effect, and not the dose that you give. So pharmacokinetics then, we can say that it is what the body does to the drug. So it's how the body deals with the drug when it enters the body. So if we, for example, imagine a patient here and you give a syringe with some type of drug, and then we can look at the concentrations versus time. And then we can observe over time how the concentrations change within the body. And this then would represent the, usually you take the blood from the bloodstream, so this is from one site like this, then it distributes, and then it eventually disappears like that. That is the basic of PK, so now you all know that. And then pharmacodynamics, on the other hand, talks about what a drug does to the body, so the other way around. And here we instead associate concentration with some type of effect, and usually it looks like this type of S-curve. And the main point here that I want you all to take away is that the higher the concentration is, the more effect you get. That is very important. And then when we talk about antibiotics, for example, the effect then would be, for example, a reduction in bacterial count. For example, you can see that here we have almost no effect, and then we have the effect, and then it's levels off like that. Yes, and here you can also see that we don't have concentration anymore, but we have exposure. and we relate that to the MIC. So that is one way of thinking about how a patient is, how much drug a patient endures over time, and then relate that to how much the pathogen can withstand. So exposure, also want to tell you that is just the concentrations times time. So it's just how much concentration you have had in your body on average over time. So yes, again, the key point, higher drug concentration generally gives more effect. Just leave it for a few more seconds so it really sinks in. And then this is, I think, a good summary of what I just said. So PK, we go from the drug therapy, so the drug you give like once every day or so on, and that gives rise to some concentrations flow. And then you have PD relating the concentrations that you have, relating that to the effect or maybe some unwanted side effect, might be measured through some biomarker, for example. And then PK/PD would then be this entire process here. So again, what we do is we model and simulate these types of concepts. And it's quite important, I would say, because here all these colored lines here represents different people, different patients getting some type of drug therapy. And as you can see, it can vary quite a bit. So if you give one dose to a patient, they might have one effect, and if you give the same dose to another patient, it might be something completely different. It might be absent or present or not. So here we can capture this black line is then called the population prediction for the entire patient population. And then we can capture like how the concentrations move in a typical patient over time, how it changes. And then we can also capture the variability between the patients, and we can explain that variability with some type of predictor, for example, their age or their kidney function or something like that. And the main goal then of all of this is to answer these three questions. How much drug should we give? How often should we give it? And for how long? This is then called a drug therapy, a dosing regimen. Any questions so far on that? Maybe you already knew all this. No? Okay. So I'm moving on to talk about this clinical trial. And in this trial, they compared colistin as a monotherapy versus colistin and meropenem in combination. And why would this be interesting? Well, it's been used in the clinic empirically, but it hasn't been verified or validated for like resistant infections. And the idea here is that in combination, because these two have different mechanisms of action, so the idea is to like get around the resistance problem for meropenem, in this case with colistin. And so the study was a prospective superiority study. It was randomized over 6 hospitals in Israel, Italy, and Greece. It was an open-label study, but blind assessment. And they enrolled 406 critically ill patients. They all have gram-negative bacterial infections. And they were susceptible to colistin, but they were resistant to carbapenems. So this is important, that they are susceptible to colistin, but resistant to carbapenems. And I think it's also good to point out that all top three priority pathogens on WHO's priority pathogens list are carbapenem resistant. And all of these were present in this study. And in fact, I think 70 or 80% of them were Acinetobacter, actually. So the idea then is that colistin, remember they were susceptible to colistin. So colistin works on the cell wall, so it opens up the defenses of the bacteria. And then meropenem works inside the bacteria. So the idea is that colistin could then help meropenem get around that resistance mechanism. And this has shown promising results in vitro, and also it's shown in combination these two we get less resistance development, so it's quite interesting to look at this. So in vitro it looks good, and now we'll see how it works in the clinic. This was the dosing given, and so colistin was given as an IV bolus, and then meropenem as a prolonged 3-hour infusion. And these were also, I have to say, adjusted for creatinine clearance, for example. So if they had a creatinine clearance below 50 milliliters per minute, it got adjusted. And it's also worthy to note that this is now the recommended dosing from the EMA that was used before. So the main result then from this study, they defined something, the primary endpoint then was something they defined as clinical failure. And here we included death, I think, up until 28 days, was it 14, something like that. Then whether they had organ failure and stuff like that. So you can see that there was an absolute difference of 6%. However, if you look at it statistically, it's not a significant difference anymore. That's mainly what these numbers says. So are there any, that was the last slide on this clinical trial. Are there any questions on this one? Yes?
Just curious to know what
What type of infections were present in the study? So there were a number of different infections. There was bloodstream infections and pneumonia, so hospital-acquired or ventilator-associated pneumonia. Was complicated urinary tract infections, and I think that was it. Those type of infections.
I'm also curious to know how the groups were randomized. How do you do this double-blinded? Do you know how that works?
No.
So do you know that both of those groups were as sick, or were the meropenem given to those that were even worse?
No. So they didn't randomize for the initial status of the patient or anything like that. So the status of the patient didn't affect the randomization process. I think it was just, okay, you have a gram-negative infection that is susceptible to colistin and resistant to meropenem, and then some other inclusion criteria, and then you get randomized. So I don't... Yes? How often it's used? That okay, so the question is that you say that colistin affects the kidneys and it shouldn't really be used. There was a debate of it, yes. Yes, so usually I don't think colistin is used in the clinic, so maybe someone here knows more of that. But for infections where you have no other option, then you have no other option than to use colistin, I think. So maybe there's some other...
I'm not a clinician by any means, but colistin is very toxic, and therefore it's a last choice. So it's probably toxic to the kidneys, and therefore it's not used very often. But like you said, it's the last option in many cases. So if it, for example, he said that these were resistant to carbapenems, so that's probably why they wanted to treat them with colistin.
Yeah. So it's actually exactly what she said. So it's a last resort because basically when somebody they know will die of the infection and there's no other way to treat it, they try with colistin because it is better to manage the side effects of the kidney problems than letting them die if you can try to save them from the sepsis.
Yes, so it's used as a last resort, I think. Okay. So then let's talk about what I did, finally. So how is colistin then associated with survival? So, because survival was a secondary endpoint in the study. This is a graph from the final paper. And here they have a survival curve, and it works like this, that you have survival on the y-axis. So you start with all the patients, that's 100% of it, and each time one patient has an event, in this instance the event is death. So if they have a death, then the curve goes down like that. And so you can see that at the end of the study, after 28 days, then we, like 40% of each one here has had an event. And what this graph tells us is that if you add meropenem to this therapy, it doesn't really make a difference. Because you see that the curves are almost overlapping here. And here we cannot assess, for example, we cannot look at other variables, so it's a univariate analysis. So it shows whether or not meropenem has an effect, but the question that we wanted to ask is, does colistin matter? Does the exposure of colistin matter in this sense? So does it matter for survival? And I will now show you a model that was developed in our group, and I will walk you through it. And it looks something like this. This is how we usually represent pharmacokinetic models graphically. So each little box here is we call it a compartment, and that is where we calculate concentrations, for example. So this part we would usually call the central compartment, and that would represent all the blood, all maybe the well-perfused organs that are highlighted here. And then this drug CMS, because you don't administer colistin directly, you administer another drug that is then being converted down to colistin. So you administer CMS here, and it can move then between these veins, if you will, and then out into the peripheral, like outside of the central compartment, the well-perfused, so you can move it into here, into the white area, for example, and back like that. And then CMS can get converted down to something I call CMS, because it's a really long process, so it's some type of metabolite. And then eventually you get to this colistin, which is the drug that gives the effect. And these arrows then are just differential equations that model like how the concentrations change between these types of compartments. And then you see also these arrows here that go out into nothing. That means that this drug gets like clear from the body, so you might end up in the urine or get metabolized by the liver or something like that. Okay, so this is how we think that this whole process works, or at least it works in when we simulate it. It mimics the observations. Okay, and then what I did was I did a survival analysis, and the good thing about this is that we can look at time and not like the time it takes to have an event, and not just whether or not you had an event or not. So we get the higher resolution of the data, and we can detect then smaller differences, because there's a difference between maybe someone who dies after 1 day than someone who dies after 14 days, for example, and not just that they died within 28 days. And it's also, we can apply many things to this. We can look for many different predictors. So it's a multivariate method. So we can account for lots of different things that weren't randomized for, and we can correct for that. So for example, then the initial health of the patient, something like that. And that is also what we did. So that's also quite a messy slide. These are all the things that we looked at. So we looked at, for example, organ function. And that could be some sense of, okay, what state is the patient in from the beginning, so at randomization. And then we also looked at some general stuff, so like the age, sex, and so on. Some factors concerning the infection, so maybe the MIC of the pathogen, or the types of infection, what type of pathogen it was, and so on. And then also the big question, the colistin exposure, and different types of ways to represent that. So here you see, for example, again, so C average is then another way of defining the exposure, and then over, for example, relating that to the MIC for colistin, for example, which is the drug we're looking at. Yes. And then it could be good to point out there that we're looking at organ function, for example, at randomization and not over time, because we think that if we look at it over time, the organ function would change with the disease. So if you would you would get healthier, then the organ function will also improve, for example. So if we only look at it from the beginning, then we sort of get around from that bias. If that makes sense. Okay, and then this slide basically tells you that my model works quite well. What you can see, the blue line in the middle, those are the observations from the study. And again, this is a survival curve, as I talked about earlier, and over the time of the study, which was 28 days. And then here, so the blue are the observations, and the green area are then the simulated data from my model. And so we have 406 observations, and I think I simulated about 80,000 patients. And this tells you that the data from the clinical trial could have actually come from my model. This is what it says. And so this was the main outcome, the survival of the patient. But you can also look at other things that the model predicts. For example, the initial status of the patient, again. And this is quite interesting, I think, because as you can see, it captures the later part quite well, but in the beginning, the average so far drops quite dramatically in contrast to the later part here. So the first week, you could guess that many patients that are in quite a bad shape, they drop off, and then that means that the average initial status lowers quite a bit and then levels off like that. But overall, I think we captured it quite well, although it might be some extreme cases here. But that could also be expected to happen. Okay, and then look at the predictors that were significant for survival in the study. So again, the SOFA, so the initial status of the patient, mattered a lot. So we had to correct for that first. And what this hazard ratio tells you that for each SOFA score, so a SOFA score ranges from 0, which means normal organ function, up until 24, which means really bad organ function. And for each score then above a typical patient, which in this case was, I think, a score of 6 or something like that, each score above that increases your hazard of dying during next day by 18%, for example. And then similarly here for age, for each year above a typical patient, which was 65 in this case, it increases the hazard of dying by 2%. And then this is quite interesting, I think. So for each exposure, for each milligram per liter above a typical patient, the hazard of dying increases by 15%. So the more colistin you're exposed to, the sooner we would predict you to drop off, so to say. And that is quite contradictory to what we might expect, because, as I said earlier, like the more drug you give, the better effect you would expect. So you would expect that the more you're exposed to, the more bacterial killing you would have. So this is the main result, and it's quite perplexing. I've tried to get my head around this, and I've looked at, for example, compared colistin concentrations and related it to the creatinine clearance, and you can see a trend here. So these are observed values. These are point values that were taken 10 hours after the first CMS dose. And you can see a trend that the higher your creatinine clearance is, the lower your colistin concentrations would be. You can also see that if you look at the clinical failure rate.
One question, Victor,
Yes.
before you continue. Why is looking at the creatine clearance ratio relevant
Creatinine clearance ratio.
to the colistin exposure?
Oh, okay, good question. Because we think that it's not actually the colistin concentrations that drive the event rates, is actually something else. So it might be related to kidney function, for example, and creatinine clearance is like a predictor of kidney function. Is that clear? Okay. It's also interesting, I think, to note that there's a trend here in the clinical failure rate. So you can see that the better condition your kidneys are in, the lower your clinical failures are, for example. So that's quite interesting to note, I think. And then also, if we look at the exposures here, and again related to kidneys, kidney function or creatinine clearance, then here the trend isn't that clear anymore. I don't know if you can see, but you have in blue the clinical successes, and they are quite a good spread of those, and the same is the case with the clinical failures. So there's not as clear of a trend here, I would say. So the conclusions that I make is that initial status seems to matter the most in this case, and the thing with the colistin exposure would probably reflect some unaccounted factor, we think. I don't know if you would agree, because we said that colistin was never toxic, for example. Another explanation could be, again, relating back to this concentration effect curve, that we might already be at the maximum effect, for example, and the more drug we give, so the further we move here, maybe we won't get any more effect out of this antibiotic. We will just maybe get some other side effect, some nephrotoxicity or something like that. That might be an explanation. And same here, you can see that if we just move further to the right here, like the bacterial count will level off here. So we think that the fact that colistin was predictive of time of death might be because Emax has been reached or kidney function was affected somehow. And then the answer, does colistin exposure matter for survival? Not really with this dosing regimen, we think. So we don't think that it is the exposure itself that drives the death rate. We might think it might be confounded by something else. Okay, that was that. And then for the future, what's next? Look at more things and try to connect back to like what might explain this further. And then also when we are done looking at this, when we have decided like, okay, what types of parameters might be important to look at and so on, then we'll compare that to what is usually done with clinical trials today and see if there's a difference there. So yes, I will just leave